Okay, let's start with the NICE guideline 2021 regarding the induction of labor, the recommendation. First one, discuss the preference about the mode of birth with women early or in. You have to discuss this thing early on their pregnancy. Okay, what you will discuss expected management or induction of labor or planned cesarean birth, and you should record this discussion of the woman preference in her note. Okay, in the early on their pregnancy. Again, you have to confirm the woman's preference for birth at antenatal visits towards the end of the pregnancy, as this may have changed since their earlier discussions. So, explain to women that induction of labor is medical intervention that will affect their birth options and their experience of the birth process. And you should explain them the vaginal examination to be assessed the cervix before doing the induction, before putting the cervipharyngeal to determine the best method of induction labor and monitor progress. And the choice of place of birth will be limited because some places the oxytocin infusion is available and continuous fetal monitoring will be required, and epidural analgesia also required. That may be these facilities may be not available in everywhere, like home birth and midwife birth units. So the birth for this they have to go for higher center. There may be limitation using a birth pool. There may be need for an assisted vaginal birth using forceps or ventus, and the increased risk of obstetrical anal sphincter injury in third or fourth degree perineal tear. The pharmacological method of induction can cause hyperstimulation. This when the uterus contract frequently lasts too long, like the more than 5 contraction in 10 minutes. And if it is like hyperstimulation, that will one contraction lasting for 2 minutes, and which can lead to changes in fetal heart rate and result in fetal compromise. An induced labor may be more painful than a spontaneous labor. Always explain the patient. The induced labor is more painful than the spontaneous labor. Their hospital stay longer with those at spontaneous labor. Discuss with them offer induction labor. Support and pain relief has to be given, and choose not have an induction labor at later stage. Then induction labor in specific circumstances, pregnancy lasting longer than 41 weeks. Give women with uncomplicated pregnancy every effort to go into spontaneous labor. Explain women if that labor usually start naturally before 42 weeks. These are the gestational age are to how many persons, like 31 is 2.4% went for spontaneous induction of spontaneous labor. At 39 to 39 plus 6 25%, 40 to 40 weeks 32%, mostly 82% deliver, and 99% deliver at 41 to 42 weeks. Using the information, there's some risk of the pregnancy continuing. If you continue beyond 41 weeks, there is some risk, like increased likelihood to risk of cesarean birth, increased likely baby need admission neonatal intensive care unit, stillbirth risk, neonatal risk. Discuss the induction labor 41 weeks may reduce all this risk, and need to consider the impact of induction of the birth experience. You have to explain that there will be some actually in the UK report there is an increase of stillbirth from the close monitoring and additional support. Compare with white babies, the stillbirth more in the black baby twice high, and in Asian country they are 50% higher. If women choose not have an induction labor, discuss the women option of sexual management and cesarean. Women who choose not to have the labor induced if they have wish to have additional fetal monitoring from 42 weeks. Monitoring remember and explain that monitoring only gives a snapshot of the current situation, cannot predict the reliable change after the monitoring end. Probably provide information how the baby is at that moment, not the whole after that some time. So may it help them decision and option of birth. Adverse effect of the baby, including stillbirth, when this event might happen, cannot be predicted and reliably prevent. Even with monitoring, you can't predict and reliable. Fetal monitoring might consist of twice weekly cardiac tachography, ultrasound estimation, maximum and depth, and STFI bi-weekly after 40 weeks. Upper women who choose avoid the spontaneous labor, discuss the decision. Then preterm labor, rupture of membrane. Previous cesarean birth, induction labor could be increased risk of emergency. Induction labor could be lead to increased risk of uterine rupture. Method of induction labor guide reduce the risk of mechanical method. You should always go for mechanical method if a previous cesarean scar. Some method used induction labor not suitable, like mifepristone or dinopristone contraindicated. Induction labor planned cesarean birth. Induction labor is not generally recommended if woman baby has breech position. It can consider induction if birth needed to expedited. External cephalic was unsuccessful or contraindicated decline. Women choose not have a planned cesarean birth. Don't discuss the risk. Fetal growth ratio, don't induce labor if there is FGR with confirmed fetal compromise upper a cesarean birth. Suspected fetal macrosomia, Option for birth are expected management, induction or cesarean birth. And induction labor, the risk of shoulder is reduced compared to the expected management. Induction labor of the risk of third fourth degree increase completely. Perinatal death, brachial plexus injury. History of precipitated labor, they don't really offer induction labor to women with history of precipitated labor, defined as first and second less than 3 hours. Intrauterine death, event of fetal support help partner. Cope. Oral preparation followed by vaginal dinoprostone mechanical metal induction if previous cesarean section. IUD induction level should be increased risk of uterine rupture. IUD with previous cesarean section contraindicated like dinoprostone, misoprostone. But a membrane sweep. Sweeping might take more likely that labor start with the need of additional pharmacological pain discomfort vaginally. The antenatal visit at 39 weeks discuss the women the membrane sweeping. Both dynamo may cause hyperstimulation, pharmacological induction. Hyperstimulation when occur, induction treatment will stop, no further medication by remove vaginal and product. Different release methods. If more than 6, we start with vaginal tablet, gel or counter release. If it is less than 6, balloon catheter induction labor. Pharmacological method not suitable. The intraoral dinoprostone beer that does not support the use of the following method induction. Intracervical dinoprostone not by the nice guideline.